And it consists of 4 different biomarkers, an N-terminal proBNP. Many of you might recognize that one. But then there are others that you might not recognize that were identified in this inductive machine learning screen as being predictive of cardiovascular events. Osteopontin, kidney injury molecule 1, or KIM1, and tissue inhibitor of metalloproteinase 1, or TIMP1. When we panel these markers together using a proprietary algorithm, the accuracy is really quite remarkable, essentially with very, very high sensitivity and specificity. The area under the curve, or the AUC, for the derivation was 0.79. For the validation, it was actually higher at 0.86. That's essentially saying 80 to 86%, 79 to 86% accurate, which is far, far better than stress testing, far, far better than other tests that we run like PSA, for example, for predicting things. And so this kind of discrimination can only really be developed when you use this machine learning kind of approach. So why do these proteins in CVE predict cardiac events? Well, we know that natriuretic peptides are a really good predictor of outcomes because they identify myocardial stress, right? You know, the heart's releasing natriuretic peptides because of something that is causing either strain or stress on the heart muscle. KIM1 actually, although linked initially with the presence of kidney dysfunction, which independently is a predictor of cardiovascular events, KIM1 has actually been strongly associated subsequently with the presence of vascular inflammation. Osteopontin also is associated quite strongly with the development of calcific coronary artery and other vascular disease, including cerebrovascular disease. And TIMP1, for anyone that's a scholar of atherosclerosis development and decompensation, TIMP1 is associated with plaque instability and the risk for myocardial infarction. Now, what we do with CVE, as I said, is we panel it out in a score kind of fashion, and the derivation and validation are seen at the top of the slide. But when you want to look at how you might interpret this, you can cut it in any different number of ways, you know, across a 10-point level, or you can just cut it low versus high. The bottom line is, depending on how many risk levels you use, you can develop an approach that gives you a strategy that can identify people with lower risk, moderate risk, and higher risk. And it's a continuous variable. So someone that is sitting at the lower end of moderate risk is nonetheless lower than someone who's at the lower risk than someone who's at the upper end of moderate. So it's important for clinicians to start thinking in a continuous manner, but in order to provide some clinical guidance, we want to make it as understandable and actionable for patients. My interpretation of the results is always low risk is better than any other level. Because if you look at, for example, the time to event analysis, those individuals that are found in the lowest risk categories have a very, very almost zero risk for adverse events, whereas those individuals that are found in intermediate or higher risk categories certainly do have a higher risk that diverges quite early. So you get both an early risk stratification that can clearly last all the way out to a year's follow-up.